Hello and welcome to today's educational webinar brought to you by Physician Partners and the Physician Resource Center. My name is Dustin Brown. Thank you for joining us today for this exciting presentation on leveraging health analytics and big data in healthcare. Today's presenter is Dr. Tyler Smith. He is an associate professor from National University and teaches biostatistics, epidemiology, public health informatics, and health informatics. He is the program lead for the associate's degree in health informatics and the newly designed and approved MS in health and life science analytics within the School of Health and Human Services at National University. He is also the director for National University Health Science Research Center. Welcome, Dr. Smith, and thank you for being our special guest host today.
It wasn't too many years ago where if I wanted to stop a discussion rather quickly, I'd start talking about statistics or analytics or data, but things are changing, and in fact, we are now in the year of the statistician, and at least one large publication's come out with a note that that an analyst is now one of the sexiest professions to go into. So things are changing, and I could talk about this and not have to hide myself anymore. I want to thank Ted and Physicians Partners for putting this on and bringing me over here and to talk about this. Quickly, I have quite a bit of background in health analytics and health outcomes research and epidemiology. My partner in all this is my wife, who's probably the better half, and she's into the biostats and the epi, and our kids are well adept at understanding the probability of achieving their dessert based on how much of their meal they eat. So we have quite a bit of probabilities going around the house. I put this in here. It used to be that folks would come up with a great idea, and we'd say that's an outstanding idea, but how are we going to get those data? Where are we going to go to find those data? And these days, it's completely flopped. People usually show up with a giant database and say, what can we do with this? I want to mention the views expressed here are mine or Dr. Basis Smith's views. If they're poor views, if they are clever, it will be all on National University. So quickly, outline, I'm going to talk about big data, and this is the fun part of the talk. Everybody's talking about big data, and quite frankly, a lot of people don't really know what it means. And I'll present to you several different meanings, and you could take from it what you will. We'll talk about how and why it's becoming big, what it means to our healthcare space, and then the analytics that enable this sort of movement, and then hopefully some trends for future big data and analytics in healthcare. So to understand what happens with big data, we have to understand what happens with small data. And it wasn't too long ago when we had folks building 5 megabyte disk packs. Those were the largest in the world just about 40 years ago. IBM saying we'd never need more than that. In '89, Gates is saying that a PC would never need more than 256, right? 40 megabytes of hard drive storage. Who sent a email today that had a 5 megabyte attachment on it? That's probably pretty normal these days. But in 2006, we had the first known quantification of what's going on, at least a thorough quantification, and it was estimated 161 exabytes of data that were created, which, to be relevant, was about 3 million times the amount of information contained in all the books ever written. So current estimate of what's happening with our cloud space, we are now estimated to be at about 1 exabyte of data, and I'll mention what the exabyte is in a moment. But you can see how many gigabytes that is, and basically in a relevant term, 67 million times iPhones worth of data. So a lot of data and very quick. We went from small to big rather quickly. We've got a transitional problem here. So our brain holds about 2.4 petabytes of binary data equivalent. That's an estimate, obviously, and this is very functional. You see somebody walk off the curb and get hit by a car, you don't do that, right? And you remember that. So very functional. We're good at quantifying what's right in front of us, but not good after that, and that's where the analytics comes into play. Google, 24 petabytes of data a day. AT&T transferring about 19 petabytes of data a day. If you see down below, we have exabytes and zettabytes and yottabytes, and they obviously, whoever is designing these names didn't have enough vision to wait to use the Z until later. But at any rate, we have zettabytes and yottabytes coming on, and I suspect with the exabytes that we're using, we will see these in our lifetime and probably much earlier. So what is big data in the world? And these are all estimates, but I've seen 2.5 and I've seen 5. I think 2.5 is probably more realistic, but it's equal to filling 30,000 new U.S. libraries of Congress. This is daily, or 50,000 times the amount of information contained in all the books ever written. It's 90%. 90% of this digital data is pretty much from the last 2 years. So if you're watching an exponential curve, we are on the upswing, and 85% of this is unstructured. This has most folks pretty uncomfortable because unstructured data is hard to quantify. You get a lot of exhaust, you get a lot of noise, and you don't get clear meaning from this unstructured data. The key to it, though, is and this is still most big companies are working on how to quantify or how to parse this unstructured data out. And once we start doing that, then in the healthcare space, it'll be like what marketing folks are doing with unstructured data and prediction of sales and that sort of thing. This hasn't been lost on the big companies who, in the last few years, have been buying up the data companies. And I won't go through these, but it's if you've been to HIMSS lately, you can see the sort of interest in the vendors at this big conference. What it means in healthcare space, though, and this is an estimate of 150 exabytes of data with 1 to 3 yearly growth. And if you remember that exponential 90% in the last 2 years, 1 to 3 doesn't make sense for yearly growth. I suspect this estimate is based on structured data, which is about 85, 90% of the data out there. So I think there's quite a bit more unstructured data, and really in our healthcare space, I think this is where the gems lie, and the ability to better predict health outcomes and set people up for better health is the physician notes. What is big data, though? Many people define this as a disruption. So we were doing perfectly fine before. Now we have data surrounding us. It's a deluge. We don't know what to do with it. It forces massive changes in how we manage data, the tool sets that are required, the skill sets, the mindset, the cultural and political will to develop databases and warehouses and how that fits in the big scheme of things. That's all sometimes defined as disruption. Many people have defined this as too much. If you've watched I Love Lucy, you remember that one where they start grabbing the chocolates as they go by, and they're popping one after another into their mouth, and their mouths are full, and they can't keep eating them all, right? Because there's just way too much. So, and I would tell these folks that you're not properly identifying your questions. If you can't eat all the chocolate that's going by, you need to better define or better give your parameters on what you're asking. Some define it as an opportunity, and this is often seen in the leadership positions, and physicians often share this point of view. It's a chance to make things better, and you know, the evidence-based or the data-driven approaches that allow us to gain knowledge that we can act on, coming from real data, and I think a lot of people see this as where we're going, or at least the carrot that's out there, even though many don't know how to get there. So a definition by Wikipedia: big data implies the need for a strategy for dealing with large quantities of data. I think this misses the mark. I truly do. And my definition would be that big data implies a need for a strategy for dealing with new data availabilities, big and small. Some of the biggest data I've seen have been 1,000-person, 2,000-person data sets that have the ability to answer a critical question that an enterprise has. And that's key. The data availability, maybe 10 years ago, they didn't have the infrastructure to deal with data. They had the same questions, they just didn't know how to answer those questions. Nowadays, the data are available. They've got to come up with platforms, integration techniques, understanding of IRBs, movement of data, and analyzing of data. So it's not about big data. It's more about the data availability. And big, obviously, is relevant to to what corporation you're at and what you're trying to do. And many of the big data sets are small in size and under that petabyte size and that sort of thing. Now, if you're trying to use these data to explore and data mine and that sort of thing, then obviously the data get bigger and bigger. But I think the big has people is misunderstood, and I think it's just the new data availabilities that may be big, depending on which setting you're looking at. Ultimately, it enables actionable information. Where's all this data coming from? So we have a patient life cycle from birth, right? A lot of things happen even pre-birth, but we'll start with birth. Medical history, demographic data, immunization data, pharmacy data. We have survey data that are coming online, biologic samples, genetic data. All these are coming together that follow a patient through their life cycle. Informed in the healthcare setting, these data come together, and oh, by the way, we're a business in healthcare, so we've got the supply chain and the financial and the workflow processes that need to integrate with all these other important areas that we're following. So you get these massive data flows coming together that will ultimately help frame the health-related issues, inform policy, and guide intervention. What does this mean? Have we hit the top? Are we done growing? And you saw from that earlier slide where we were the last 2 years, 90% of our data, it's going up exponentially, and this is going to continue for some time. We're 50% adoption is a low, obviously, estimate. I think we're closer to 70% now, but we're still in the adoption phase. We add 30 million insured folks this year. We're going from a 2.6 trillion or 16% of the GDP to 4.6 trillion by 2019. We're going from ICD-9 to ICD-10 codes, and the procedure codes are going to be revised also. And we have a huge problem with chronic disease and multiple disease states and comorbidities, which are only going to get worse before they get better. So data are going to be increasing for a while to come. What do we do with these data right now? Well, we can answer this. This is our dilemma in healthcare, right? We all expect the highest quality of care, the universal access, and we want the lowest cost. And I'm not sure if folks would completely agree that we have all of this. We have the CDC reporting that there are an estimated approximately 100,000 deaths annually that are associated with preventable medical errors, which is more than diabetes. And we have Institute of Medicine coming out with medication harming 1.5 million people in the United States. So these are things that hopefully with some of the informatics solutions that are coming to play currently and the analytics that we can start to drive down and really gain the categorization of high quality care. With all these informatics solutions that we've focused on in the last decade, and oh, by the way, we would have been doing this without Congress getting involved the last few years, although of course that's put it on overdrive. The informatics solutions in every field have been incredible over the last decade. Finance, banking, marketing, business, it's all the capability has presented itself, and all these groups these industries are embracing it. So we would have been doing this anyways, but what's happened in the last few years with meaningful use and affordable care, and this has been just put on a higher level of completion than maybe we would have gotten to on our own. Still, the informatics solutions are for the most part in their infancies, though they're building steam, and there are definitely mature data sets out there, and time in most settings to start to talk about how you integrate analytics into this. And first step would be some sort of reporting, evidence-based use of or data in evidence-based approaches to your practice and maybe the business side of it. But soon we're going to be starting to look into this in the aggregation and population health sort of approach. And you probably have heard about the 3 V's. We've got another one. So we have volume, velocity, and variety. I included veracity in there, and that's the one we're looking at now. And soon you'll start to hear it pretty much said as the 4 V's. And the veracity is the quality of data that we're looking at. So we have the volume, and we have how quick it's coming at us, and the different platforms, different types of data, and then the quality of those data that we might be making evidence-based decisions on. So all that to say, our usual statistical approach of hypothesis testing that our traditional stats folks have pushed for years, that's evolving too, and it's mostly because folks in the banking and finance and marketing industries have been using different approaches such as data mining, and oh, by the way, there aren't the assumptions and everything that go into the approach that we would normally have with a logistic regression or hypothesis testing approach. It's pretty much, if it works, they sell something, and if it doesn't, they don't. And they've come up with great models that are not traditional, that excellent predictive capabilities. They know who will buy what. They'll know who will default on which loan, and they these same tool sets are starting to be used in the healthcare setting because they work, not because they're testing a hypothesis, but because they're using the massive databases that are out there and coming up with ways forward. They're exploring and data mining and through classification trees and neural nets and different predictive approaches, they're showing great promise. So you have to think of this as a complement to the traditional approach and as we move forward with analytics. So I was trying to think of a way to present this that was more relevant. When we talk about volume, velocity, variety, veracity, boy, that sounds great, but that sounds interesting probably to a data person, and maybe not to somebody that's in the trenches with patients. And so I came up with the 4 R's, and you won't have ever heard of this before because I just came up with it and I did a search and couldn't find anything like this. But it's patient-centered, and we're focused on the risk, the retention, the revenue, and reliability. Revenue reimbursement, so I could put that one in there too, but revenue seemed broader. So the 4 R's that match up with volume, velocity, variety, and veracity are the risk, retention, revenue, and reliability. And what this means, risk would be in terms of patient health outcomes. That's what we think of at first. You think of prevention, both where we're going with behavioral and genetic education. We look at patterns and prediction of diagnosing, procedures, prescribing. We look at prediction and how we can stratify populations or profile patients and gain more efficiencies. And we also look at risk adjustment for practices seeing different groups of patients that might be a higher risk that will allow us to stabilize or at least level the playing field so that folks that are physicians that are seeing a higher risk group aren't punished. We look at retention, and this is we're a business at the end of the day, and we want our customers, our patients, to be satisfied. We want them to stay engaged with us, and we want to retain them ultimately. So the retention aspect is the prediction, and we have automated calls already and that sort of thing. But that's all kind of part of the informatics and not necessarily analytics. Analytics is when you bring it to the next level, and you identify solutions that are using predictive approaches and driving up your retention or your ability to satisfy the patient. The revenue, all the business folks and the marketing and the finance folks are well aware of how you use analytics in the business process. But there are still areas we can refine, such as supply chain, and that's obviously the second largest cost next to labor. The delivery of supply, the amount, the location, that continues to be an issue. And the increase of reimbursement rates. And I know that's a lot of, I know Ted helps a lot with that, and he and I have had quite a few conversations on how we can drive up the reimbursement rates for physician partners. So there's the revenue or the reimbursement area, the reliability, and this is what everybody expects, and that's quality of care, high quality of care. We need standardized quality metrics that are automated throughout a system that can throw up red flags, that can throw up a crossing of a threshold. They need to be portable. So when I go to a hospital here or a clinic here, I get the same care if I'm in visiting Florida or Kentucky. We get the same portable quality of care, and it needs to be integrated so that we can see this seamlessly and from wherever we're seeing a physician or caregiver. The challenges, and you probably all know that these more than I, but integration of data from multiple and complex environments. This is just flat out difficult, and unless there's a carrot out there or a stick maybe that's coming, there's going to be turf, and the people who own big chunks of turf aren't going to be excited to hand over big chunks of data that they will often use as currency, if you will, to gain grants or to gain collaborations that might bring in revenue. So the turf areas of data are difficult, and they will probably only be overcome with the carrot and the stick approach. Standardization of data elements. I don't know how many data sets I've seen that will call a simple variable like gender. They'll call it sex, and they'll have male and female. And I've got a colleague that just recently mentioned that, yeah, well, there's 3 levels of my sex variable. So there's just a simple variable like that, and you right away get the train wreck if you try to merge data sets. We still have an issue with respect to privacy and security standards and the portability of these. And even across an enterprise, you'll have differing levels of it. And so we're not there at an enterprise level, and we're surely not there at a more global level. Standardize the risk adjustments for providers. This is key. Otherwise, in this new climate, there will be larger and larger difficulties in finding care for some of the people that have many, many comorbidities. And ultimately, there has to be a political will. And this is something that I think we're at in most places, but again, you know, there is still the lack of complete both feet in with respect to some of these analytics. The last one is the unstructured data space. That's where most of our information now sits, and quite frankly, we just don't have a good handle on that. We need to use or develop things like latent semantic analyses and different parsing of data to not just word searches. The word searches don't count in this, because you need the negatives, you need the affirmatives, and you need to quantify what the words are trying to get at. So that's a large challenge, especially with so much data residing in that area. What I see as something that we can do at a fairly short amount of time, develop more prevention strategies that are integrated into the primary care setting, the population health management sort of model that everybody seems to be embracing. It needs to roll out and get some standard prevention strategies that are across the board. Geospatial analyses, things like immunization coverages. It's amazing to me that when an outbreak happens, we don't know immunization coverages to a perfect extent. And this sort of thing from a public health, community health point of view is something that I think we can do and should be able to do and be able to rush immunization or vaccine to an area that might be going through an outbreak. Population-driven individualized probabilities for best care. What does this mean? Well, we're sending all these data up, and they keep going up, and they go into this cloud space, and we never see it again. But the real benefit comes when we attach all these probabilities, all these trajectories towards disease, all these behavioral modifications, all these different points that an individual may have. We put the probabilities on at a population level, and then we drive it back down to the individual level, so that a physician or caregiver or a clinician in the office can say, here are your probabilities for various diseases, and these are the ones we really need to watch based on your genetics, based on your behaviors, based on your past care, based on all of your variables. And this is what we really need to watch and make sure we're tackling before, as part of our prevention strategies. Areas of refining supply chain. Not having enough of something or having too much is just, quite frankly, not a good business model, and there are prediction models out there that can solve this. And the risk adjustment. This is something that is highly contentious, and it's something that we should be able to solve as a industry fairly soon, but we'll see. Ultimately, sky's the limit with this sort of data that we're putting together from the informatics and the types of analytics that we're capable of doing. And ultimately, that's what we want to do, and change data into information, into knowledge. In summary, we have the informatics platform that we're driving the analytics from. So the data management, the standardization, the integration, and then the automation of analytics. And I'm not saying that an analyst needs to sit somewhere and run model after model. This should be able to be built in a fairly automated way, and following the finance or the marketing approaches that have been so productive for them. I think we can gain a lot. Ultimately, within your own enterprise, you need to understand what your mission and vision statements are, and how your data may answer your question. And when people come to me, and they come to me with a massive data set, I often say, well, that's a really big data set. Do you really need that? Or could you have taken one of these tributary data sets, these smaller little rivers that combine to make this giant data flow? Could you have done with that? I mean, could you have answered your question with that? And oftentimes, you'd be amazed at how much you can answer from the trickles, the smaller data sets. That you may want to do a 30-day readmission study. You may want to look at something in diabetes, and you have a small data set that isn't part of or maybe part of the big flow, but you're not pulling it out of the big flow. So again, make it relevant to what your needs are, and at the bottom line, you need to come up with your objectives. And that's it. Want to just say thank you to Ted and everybody here, and mention that the health analytics program that we built over at National is in full swing, and we're going through with our first cohort currently, and I hope to come out with some great analysts soon. So.
Do you want to maybe we have time for a few questions at all, Doctor?
Oh, sure.
Okay. If anybody has any questions, they're starting to roll through. Just go ahead and type them into the GoToWebinar interface, and we'll be able to receive them on our end. So there's your first question. Is that showing up all right?
So David, Dr. Lemberg, big data, the current buzzword, is primarily noise, as you know. The importance may lie in creating actionable information. What types of analytics research are being done on the patient side rather than on the third-party profit? Well, there's a lot of health outcomes research that are ongoing. And you're right in that there's probably more done in cylinders right now, and not enough being done at the population health management level. But I think that's where we're heading to, and most of it comes down to what's available in the data sets. And our administrative data sets are much more mature than our outcomes and our clinical data sets in terms of being in a warehouse. Where you can get more info on prediction models for supply chain management. I can send you something, but these are mostly in business areas for supply chain. This isn't something that that's new to the business aspect of it. It just seems to be newer to the healthcare setting, and I've got opinions of why that is, but I think we're just being held to higher standards these days, and we need to make do with less. So I think that's why it's important. D. McNeil, important to focus on health disparities and how to improve outcomes. Exactly, and that's it. No matter where you go these days, you find that health disparities is in the forefront of the discussion. And what will happen with a lot in the next few months with the 30 million folks that are being insured and the evolving space is to understand who's getting what care and making sure that obviously there are no or we reduce or mitigate the disparities.
Okay, looks like we have another question here.
If I'm using a standard EMR, how can I additionally add to data collection? Where's the easy start? If you're using a standard EMR and you're an individual physician, there should be a data flow to a warehouse, and I think that it takes some setup that I know, Ted, you went through with recently with respect to the dashboard, but once you identify and come up with the middleware, the integration tools, you can start to put these EMRs into a warehouse that is more robust and covers your group. Did I answer your question?
Okay. Well, thank you very much, Dr. Smith, for hosting this webinar. It's very interesting, and we appreciate your time very much. And thank you for everybody that attended today, and we look forward to seeing you again next time. Have a great day, everyone. Thank you.